Hello. Here we're going to talk about the modern vision correction procedures, give you a general overview, talk about who they might be best for, and also show you what they look like. The 7 methods available for vision correction in the United States are here. So the first one is OICL, or implantable Collamer lens, LASIK, laser-assisted in situ keratomileusis, SMILE, small incision lenticule extraction, PRK, photorefractive keratectomy, RLE, refractive lens exchange. This is also sometimes called lens replacement. FLACS, femtosecond laser-assisted cataract surgery. This is a modern and advanced form of cataract surgery where we use very precise lasers to assist with certain steps of the surgery. And CTAK, which is corneal tissue addition keratoplasty. I hesitate to call these options. It might be good to not think of these so much as options, but as you know, every eye is unique, and every procedure then fits a unique eye. So depending on the patient's goals, wants, needs, lifestyle, personality, there will be a best procedure and there won't necessarily be options. Patients might qualify for several procedures, but at the end of the day, there are not as much options as there's one unique solution to each eye and situation. Talking about them individually, first here is EVO-ICL. So EVO-ICL is often called an additive technology. That means instead of lasers or removing tissue in some capacity, we're actually adding a lens. This is really important. In my opinion, it makes them the least invasive form of vision correction. That means at any time, for any reason, even though we normally don't anticipate it, the lens can be removed, upgraded, replaced, exchanged, and the eye remains in its original anatomic state, which I think is really cool. They're available in up to starting at -3 diopters and higher of myopia correction, so no hyperopia in the United States, and they're available up to 4 diopters of cylindrical correction. They come in 4 sizes, 12.1, 12.6, 13.2, and 13.7. What the sizes actually refer to is if you draw an imaginary circle around the ICL, it's kind of taking this diagonal measurement highlighted in red there. There's been over 3 million implanted worldwide, and there's really this idea of an EVO revolution recently, so they're safer than ever. Sometimes patients ask, well, why haven't I heard about this before? And the answer is, well, it's not new, for one. EVO-ICL, or ICLs in general, go back to the 70s, 80s, and 90s. The first ICL was really implanted in the 90s, so it's really as old as LASIK. The question for a long time was, is it safer to remove cornea and reshape the cornea or to add a lens to the eye? For many years, the answer honestly was laser is safer, because if you Google things about ICLs, you unfortunately might see things about glaucoma, angle closure. Well, in 2022, the EVO revolution kind of began, and the big innovation was adding that small port, a 360 micron central port to the actual ICL. This means some of those old concerns like cataract, glaucoma are effectively impossible now, because there's always a way for the aqueous to be cleanly moving through the eye, because if you think about it, the pupil can never constrict around that very central port, so there's no mechanism anymore for those high IOPs as long as the procedure is performed correctly. And what are the ICLs actually made of? Well, if you look at this comparative picture here, they're very similar to contact lenses kind of in feeling, but they're much smaller just because of where they're sitting relative to the eye's optical system. 60% of the composition of this Collamer, which just stands for copolymer material, is kind of that hydrocellulose, hydrogel contact lens material. It's a very hydrated material, so a big component of the actual material is water. There's a little bit of hyaluronic acid. I kind of demonstrate here as lip filler, and there is a UV blocking element within the lens, so they do block UV light from making it to the natural crystalline lens or the retina, which is another cool feature of them. The indications per the FDA for ICLs include age 21 to 45 and having an internal anterior chamber depth of 3.0 millimeters or greater. By internal anterior chamber depth, we mean from the anterior lens capsule to the endothelium. So most of the time when you see anterior chamber depth on the Pentacam, if you're kind of just glancing at it and not paying attention, it might be external anterior chamber depth, which actually measures from the epithelium to the anterior portion of the lens. So just make sure it says, INT to indicate the lens capsule to endothelium, which is, truly just the anterior chamber volume space. Like I said, you have to have up to 4 diopters of astigmatism. spherical equivalent refractive error of about -3 or greater, and generally healthy eyes. So no advanced glaucoma, no significant endothelial disease, or significant risk factors. Generally healthy eyes overall. That being said, myself, many others as a group, were very comfortable going off-label. And what I mean by that is, why shouldn't an 18-year-old with a very stable refraction qualify? Why shouldn't a 49-year-old qualify if they have high myopia? Because blended vision can work very well for ICLs as well. Using advanced imaging techniques, which we're very dedicated to, we're able to expand the horizon for also who is able to be treated with ICLs. And what I mean by that is we don't have to stay so rigid with the 3.0 millimeter cutoff. We've gone down to 2.3-ish range. So really, if the ACD is 2.4-ish, the anatomy looks good, and we do our due diligence with the scans, it's very possible the eyes would still qualify. These are also great to use as a tool for astigmatism debulking or myopia debulking. So you can have 6 diopters of astigmatism and be like -18 for a keratoconus patient. Well, you can bring them from the stratosphere into kind of a functional range where contact lenses don't have to be so thick and customized. So there's a lot of actually flexibility, I think, with the ICL. So with the patient selection, like I said, we really consider anyone who's 18 or older, about -250 spherical equivalent, and you think about that, it's just accounting for the vertex distance. So if you're around that, the -3 lens should work for you. Appropriate anatomy, and what I mean by that is, I'm not saying every single 2.3 or 2.4 internal ACD qualifies. It's just taking a look at the whole picture and doing our due diligence with the studies and seeing if you have reasonable anatomy to accommodate the actual lens. They have a particular advantage with certain patients, so they really shine with myopia of -6 or greater, and that's really due to vertex distance. So I often ask patients, to look in the mirror. Maybe you've done this yourself. You notice when you're wearing your high prescription myopia glasses, sometimes your eyes look smaller or the side of your face looks moved in relative to the glasses frame. And that's because a high minus lens is kind of like a reverse telescope. So looking through a telescope backwards and everything looks smaller. So you get this minification effect. That minification effect is reduced by changing vertex distance. So contact lenses have less of that minification effect. LASIK has even less because you're working closer to the nodal point of the eye. Remember the center of the eye where all the light rays start to flip. ICLs are really close to that point, so that means that you get the least minification possible. So I like to tell people, the world is actually going to look 10% bigger after your procedure, and it's not like Alice in Wonderland where suddenly the room is huge, but it's like details on the wall are easier to see, and you might find yourself reading further down the eye chart than you ever have. Also, with treatments greater than -6, the lasers, they are very well optimized nowadays, and there's different types of LASIK that we'll talk about in a second, but you certainly run the risk of more dysphotopsias or irregular surface afterwards. So anything over -6, the literature is pretty consistent that ICLs tend to shine. They're also really good for those who value future flexibility and that reversibility component. So like I said, we're leaving the anatomy of the eye intact, and what that means is 40, 50 years from now, whatever cool technology for IOLs is available, they're coming out with multiple IOLs every year now. Whatever is available at the time, you're way more likely to qualify for if we haven't changed anything about your cornea, and the biometry and things can be performed as normal, again, because your eye is in its original anatomic state you were born with. Also, those with pretty significant pre-existing dry eye will really benefit from ICLs just because we're hardly touching the surface of the eye, disrupting that feedback loop. So there's actually very little irritation, even temporarily in the short term with ICLs. So what generally does the pre-op process look like for ICLs? Well, of course, everybody's going to undergo a manifest refraction. A cycloplegic refraction will tell you both about, are they over-minused right now? What's their accommodative reserve like? We often do a contact lens over refraction for those patients kind of in that -7 or greater range of myopia, just to eliminate vertex distance and get even more accurate spherical measurements. think a pentacam is really important for sizing because, like I said, you can really accurately measure that internal anterior chamber depth. And we often use UBM for sizing because, as you know, UBM has that benefit of looking through the iris, so we can actually see and measure the space where the ICL will ultimately be sitting, which is, of course, the sulcus. So here, there's honestly different types of UBMs available. The ARC scan has a great nomogram, the Reinstein nomogram. Sonomed has the Parkhurst nomogram, and then the AI-driven nomograms include things like Guru and Vault, and these are just more ways to get more information, which, like I said, allows us to really expand those horizons and help more people than ever before with ICLs. I just included this picture here of what a 13.7 ICL looks like in an eye, and the point is really you're not going to be able to tell, right, what the size of the lens is because it should fit the eye and look right to that eye. So a 12.1 in one eye should really have kind of the same proportions and ratios as a 13.7 in another eye. I will say we are extremely, extremely dedicated to sizing accuracy, and we have just published so much literature on this, and we have really made it kind of an area of focus for ourselves to be really dedicated to just delivering the best outcomes possible. So we've just published a lot on this and continue to, and are really excited kind of for what the future has in store for ICL sizing. I'll say with the EVO ICL, sizing is a lot less important than it used to be. It's a lot more tolerant to a wider range of sizes than the legacy Visian ICL was. That being said, we're always looking for perfect. If you can make things even 1% better, I've always believed you should be trying. So that's what we continue to do. Here's what the procedure itself looks like. So we start with a 1 millimeter paracentesis. We slightly enlarge just to make manipulation of the lens a little bit easier. We often do a combination of epinephrine and lidocaine, or phenylephrine and lidocaine, just to both improve dilation throughout the procedure and make the whole thing more comfortable because we are manipulating the lens around the iris. Then we use a OVD, which is also just kind of hyaluronic acid to stabilize the eye, same thing you would use in cataract surgery. We're very careful not to overpressurize the eye at any point during this procedure because these are young myopes, they'll be more sensitive to that, so we just try to take extra care here. Then we make the main opening for the lens to actually be inserted. This has to have a minimum of 2.75 millimeters. We often just use 3.0 millimeters, so we're not feeling that we need to force anything. This is a very similar also to a cataract main incision, and it can also be used later for cataract surgery too. So through this main opening that we just made, the lens that we prepared before, they don't yet come preloaded, so we spend a little bit of time before the procedure loading them, can be inserted here in this kind of push style injector. So we're watching kind of the leading haptics there, and if they open in the right orientation, you're kind of made. So this was a nice clean insertion here. Add a little more OVD to protect the endothelium. We're taking great care to protect the endothelium and the actual lens capsule throughout the whole procedure. It's kind of the two things on the front of my mind all the time. Then we use this little manipulator, and like I mentioned, the ICL needs to sit in the sulcus space behind the iris. So we need to tuck it back there. This is done usually by grabbing its outermost extent along the very edge of the foot plates and tucking it where it needs to go. We work through that side port paracentesis first and then through the main incision here. So that's what it looks like when it's in place. That was maybe 2 minutes and the procedure is done. Now what we have to do is remove that OVD. So really the only time you're thinking about pressure with EVO ICLs, because like I said, the old mechanisms for pupillary block and things are not possible anymore with that central port, are in that immediate post-operative period, like really 30 minutes afterwards, and that's just due to residual OVD. We don't routinely prescribe things like acetazolamide or any pressure-lowering agents because we are fairly, especially, I really spend a lot of time with this rinsing of the OVD out of the eye here. So kind of wash it off the endothelium gently and then wash it off the lens gently. You might see others doing this using IA and things. This is just the method recommended by the company, and I think as a group we've developed different methods to kind of perfect this over time. So it really minimizes the disruption to the lens or the endothelium, and also minimizes the risk for pressure elevation afterwards. This process is a little tedious. I like to joke with patients that the procedure's pretty much over, the lens is in and in position, but now we just have to do the last rinsing steps, and that really takes as long, if not longer, than the entire rest of the procedure. So here we're just continuing to wash out the OVD material. You can see, even though this is all clear on clear material, right? So you're looking through a clear cornea into clear aqueous, and then you're looking through a clear OVD, which you're trying to rinse out, on top of a clear ICL, on top of a clear lens. So it's a lot of clear material. So you're just looking for clues, which is like bends in light or shadows. And hopefully you've been able to appreciate some of those during this rinsing part of the video here, as we just try to get the rest of that OVD out of the eye. While we're rinsing, again, like I said, we're taking a lot of care not to overpressurize the eye at any point, just to remain as gentle and focused as possible, keeping the eye kind of on the softer side, and never pressurizing too much or allowing the pressure to drop too rapidly, because again, patient comfort is a big part of refractive surgery. They kind of directly correlates to outcomes, right? So the more comfortable patients are, the less they'll be wiggling around and moving, and honestly, the better their surgery will be. So here we're continuing to rinse. I think this whole procedure goes on for like 5 or 6 minutes or so. So the procedure is really quick. You can correct 16, 18 diopters of myopia in one go here. So that looks really good. Sometimes we rock the lens around just to release any of the additional OVD that's trapped behind the lens. Again, this looks pretty good. So the last step is to, again, leave the eye on the softer side, which we achieve just through strategic burping, but inflating at the same time, because again, we don't want any sudden changes in IOP, certainly. And after we're satisfied with that, we'll just do a quick antibiotic drop, and then the procedure's over, really. So that's just checking the pressure. Then we'll do that drop of antibiotic. We don't routinely put antibiotics in the eye. There's certain risks to young people iris with the antibiotics, so we just think less is more. So look at that. That was like under 6 minutes, and changed people's lives. So it's really awesome technology. So the post-op is us or the patient's normal eye doctor that they're used to seeing. We'll see them usually 1 day, 1 week, 1 month, and then it's back to routine general eye exams. On 1 day, what we're really checking is the IOP, the vault, and the visual acuity. I'm expecting 20/20 or better, honestly, on day one. Vision comes back really quick with ICLs. I'm talking like hours, so it's really incredible. Like, patients can be just coming out of the OR and able to like read their heart monitor and things. Vault is the measure of the space between the anterior crystalline lens, so the capsule of the lens, and the posterior section of the ICL. This can be measured in many different ways. One very common way is just with a machine that most people have in their office already, which is just like the Zeiss OCT. This is a example of that here. You can see on the kind of top part of the screen the ICL, and then the crystalline lens underneath. This kind of artifact that you're getting is actually of the OCT shining through the port. So that means you're getting a nice central section of the lens, which means it's nice and accurate. And you just place these calipers and you get a measurement here. Vault changes a little bit over time, but nothing substantial. And like I mentioned, vault is just not as important of a component anymore. And there's really no numbers that you should be chasing. The company has recommended between like 250 and 900 microns, just based on the relationship of the vault to the cornea. But like I said, you can't get too attached to vault. Different eyes require different vaults, and the ICL, the Evo version, is extremely forgiving with a wide range of vaults. And again, after that 1 month, it's just typical eye exams. We typically give patients a pair of goggles to wear at night just for the first week so they don't accidentally rub their eye. And then we'll also give them an antibiotic to use 4 times a day just for the first week. It's an antibiotic with the steroid. You don't need any fancy equipment, honestly, to measure vault either. Here's an example of measuring vault just at the slit lamp. So you can express it as percent thickness of the cornea. So if you kind of separate the slit beam and the slit lamp that you're looking through, kind of at this like 45-degree angle, you can get this really nice view of a section through the cornea, which you can gauge cornea thickness, and then the vault as well. So in this example, you could say it's about 50% of corneal thickness, or closer to like a 250, 300 micron vault. Like I mentioned, vault is really not the whole story. So large eyes are obviously going to require a larger vault, right? And smaller eyes, the vault might be smaller. So don't get attached to numbers. If you see something like a 1200 vault, that's not necessarily reason to panic and exchange the lens. I mean, if you can see, this is an example of a, what initially would seem like a large vault, but look, these angles are like 30 degrees. So it's the right size. It's the right size lens. It's the right vault for this eye, and it's kind of a perfect outcome for this eye, even though it doesn't, kind of fit in the box. So, like I said, there's refractive surgery is kind of like an art, right? So we're not, getting too attached to certain numbers and things, and looking at the whole patient and the whole picture a lot of the time. So here's some co-management pearls for EVO ICL. So for one, that central port should always be visible in the kind of center of the pupil, and that might be the only thing that you see from the ICL too. It's a very clear material. EVO doesn't require any LPIs. You might have heard some of the legacy version of the ICL did require the LPIs, either with the laser, the vitrector, or something. Just again, so the fluid always had a way to flow through the eye. With that central port, that's not necessary anymore. Certain iris colors, things like that, there might be a little pigment dusting on the lens just from the initial insertion. That's okay. It's effectively never visually significant, and it usually doesn't change very much over time. If IOP is elevated, I think it's important to check both the horizontal and vertical meridian. Almost all the time, the ICL will be sitting horizontally, which means it's only raising the iris in that meridian as well. So just check gonioscopy in the other direction, because it's likely those will be significantly more open than the horizontal meridian. Vault shouldn't change much with EVO, and it's also a lot less important. So you get kind of one good measurement. You don't really have to think about it a ton afterwards, unless it's like way low or way high, and you have really narrow angles and maybe some IOP issues. So it's just not something to stress about as much anymore. If there's any refractive changes, the first thing to think kind of is like a rotation, especially with the toric ICLs. They're possible, but extremely rare. The signs kind of include a sudden increase in cylinder, and it's going to be mixed astigmatism, and it's blurring of vision. It's usually totally random too. So, I mean, the rotations that I can remember, people have told me either like, oh, they were just sitting on a plane, and the next thing they noticed their vision was blurry, or like they went to bed one night, woke up the next morning, and it was blurry. So you can't like, thrash your head around or do a cartwheel or rub your eye really hard and have the lens move, because again, if it's sized correctly, it has a really stable position within the eye. Like I said, almost always spontaneous and very rarely related to trauma. So glare gets much better with time, and it may take weeks to months. And there's less patients think about it, the faster it resolves. I like to tell people it's like your left shoe. Like you put on your left shoe this morning, you kind of felt it as you like tied it or whatever, and then you haven't thought about it since, because it's not useful information to be sending to your brain, right? So your brain is going to filter out this glare. Annual eye checkups are all that you need, and there's really no special monitoring necessary with EVO. Just one more note on that glare. I like to tell people the glare is going to be there at first. Like, really just expect to see that. It really manifests as a kind of concentric rings centered on your vision. So if you like move your eyes around, it's going to follow your eye. That also means that it's never going to be in the center of your vision. So it can never like obstruct driving or anything. And it kind of, the rings change size based on the angle of the light source. So if it's like a car driving by and a headlight is causing it, the rings will never be in the center of the vision, but they'll kind of change size as the car drives by. They improve drastically over weeks to months at most. And here is a extremely accurate rendering of what the glare and halos look like. EVO ICL does not impact cataract surgery. This is a legacy ICL because, again, they've been around long enough that the original patients who got them 20, 30 years ago are getting to cataract age. So we'll talk about FLACS a little bit later, but here is a femtosecond laser surgery happening through an ICL. So it's going to first make the rhexis. So if you can see, that little special purple flash is actually the laser coming up into the ICL a little bit, and then it divides the lens into segments like it normally would, and then does the arcuate incision there. So again, you can hardly tell the ICL was even in the eye. No special adjustments for biometry are required or anything. So it's just really non-invasive in my opinion. This is that same lens, kind of the first thing you do for cataract surgery is take it out of the eye. So here it is with that kind of ring that I mentioned cut into it from the rexus. And look how pristine it looks, really. So there's no scarring, there's no fibrosis, there's not a ton of pigment on it. It really looks as pristine as the day you put it in. So it's just really biocompatible and non-reactive. What actually happens when you put it in the eye is it kind of immediately becomes coated with fibronectin. So it becomes like kind of an immune privileged entity, and it just is inert kind of for the duration that it's in the eye. I'm a big believer in practice what you preach. So this is the ICL sitting in my eye. So Dr. Parkhurst did my surgery in 2023. This is my wife. I did her surgery in 2024. So a big believer in the technology. The things that spoke to me particularly were the reversibility and the fact that it really doesn't change the anatomy, especially as someone who's prudent and likes to plan forward. It's just kind of nice knowing that whatever accommodating AI, high-tech X-ray vision lens is available in the future, I have a better chance of qualifying for. So now we'll talk about LASIK, which is kind of old reliable. So first of all, when somebody says LASIK, oftentimes the public, they mean ICLs, lens exchange cataract surgery, because that kind of means any form of vision correction. But even kind of more confusingly, there's multiple types of LASIK now. So there's wavefront optimized LASIK. And what I just mean by that is, the LASIK is not treating the entire cornea, right? It's only treating the section of the cornea that you're looking through. So you can't just have treated cornea and then abruptly move to untreated cornea. So the wavefront optimized just means it smooths out that transition zone to reduce the amount of aberrations that the cornea would experience afterwards. There's Contura, which is topography-guided LASIK, which it takes into account all the tiny irregularities of the surface of the eye. There's a couple different versions of topography-guided LASIK available. And kind of the newest iteration is Wavelight Plus. So what Wavelight Plus is a ray tracing-based LASIK, so it really takes the optical characteristics of the entire eye, including lens, to kind of correct everything all at once in the cornea. I like to call it old reliable. It's just excellent for myopia and hyperopia. It's kind of like the workhorse treatment. It's had the benefit of being iterated on for 30 years, kind of similar to the ICL. So the lasers are on like their 5th or 6th generation. So it's really just getting kind of better all the time. It's been like 20 million cases worldwide. Kind of the most important thing with LASIK, just if you remember one thing, is the importance of screening. So poor candidate selection is really what harms credibility. I know if you go to TikTok or Instagram or whatever, there is a lot of negativity towards LASIK or vision correction, but if you track down almost all of those stories, it really comes down to bad candidate selection. So like I said, these procedures are not options. They're not one size fits all. Every eye has a unique procedure, a unique set of needs, and a solution that will fit that eye the best. And that's not always LASIK. It's not always ICL. So again, that's why you have to go through these screenings, get all the information you can, and kind of tailor a treatment plan to the patient's wants, goals, needs, and things like that. Here is just a case of LASIK. So the first thing is suction is used to stabilize the eye. All modern flaps are cut with a femtosecond laser. So the laser first kind of cuts the width of the flap, usually about 110 microns. And then if you watch on the sides there, it will cut the side cuts, but leave that bottom portion of the screen attached, which is what will eventually be retracted. So afterwards, we just use a flap dissector to free it first, and then lift it out of the way so the laser can do its part. Obviously, the big difference between LASIK and PRK is the presence of the flap. So once the flap is moved out of the way, all the programming has already been done in the laser and already been confirmed and everything. So then the laser will automatically track the iris and adjust for astigmatism and things. That usually, and here is actually the treatment, so you can see all those little dots of light treating the actual cornea. It doesn't matter if you're moving your eye around a little bit, the laser will follow you. And it also really doesn't matter don't tell anybody this. If you like look away, it's not going to like hurt you or do anything like that. The laser is tracking you, so it will shut off on its own. Oftentimes the surgeon will turn it off, but the laser is a lot smarter and a lot safer than I think a lot of people give it credit for. So, it is tolerant to small eye movements, and it has a lot of safety features that will, automatically turn itself off. So after kind of placing the flap back, making sure it looks nice like that, we'll just kind of dry out the gutter, which is the space between the actual flap and the rest of the cornea. If you can see here, you kind of dry that out. It helps with adherence. So that kind of circle went all the way around. That means, it's a nice even gutter. The flap is nice and centered. So this looks great. And, again, what was that? Just like 2 minutes for the whole procedure. We do an antibiotic and then, do the other eye. So the whole procedure is really quick. It's painless, easy, and over before, most people realize it even started. Smile is, more like 2018 when it became widely available. It's a femtosecond lenticule extraction. So it's just kind of taking a different approach to vision correction. It is a type of laser vision correction in that it's reshaping the cornea, but it's achieving that in a much different way. So we can accomplish this by myopia treatment only. Again, the range for Smile is from -1 to -10 with up to 3 diopters of cylinder. Who this is great for? Well, boxers, MMA fighters, people who take care of trees and things. Anytime you're getting hit in the eye repeatedly, this is a great solution because it's very painless and there's no flap or anything. It definitely shouldn't worsen dry eye either, just like the ICLs, because again, the actual only incision on the surface is extremely, extremely small. If you kind of see it at the bottom of that picture there. It's been over 10 million cases performed. It's really safe. Another really kind of significant benefit of Smile is that there's really no restrictions, because again, there's almost no manipulation of the eye. So, that just means people can get back to makeup, swimming, doing their kind of normal activities faster. So here again is just a quick case of Smile. I can just narrate this for you too. I think I turned the sound off here. So it's all done with the femtosecond laser. So first it's cutting it's called the refractive cut. So this is the part that's actually going to flatten the cornea. It does that. It's the back side of the lenticule first. Then it does the side cuts, and then it does the cap cut, which is kind of defines the top part of the lenticule. So, again, we're really making like a lens-shaped piece of cornea that will be extracted, and the very last thing it does is make that opening. So there's lots of different ways of removing a lenticule. So I'm not saying my way or this way is the right way by any means, but so I like to do the kind of make a sweep across the anterior plane and then find a little pocket in the posterior plane. So at least we have the planes defined. One of the huge pieces of advice with Smile is just like knowing, you got to know where you are. So like look for all the context clues to make sure you're in the right plane. So then we reach in with this dissector, and we're going along that cap cut of the lenticule. So again, we're anterior to the lenticule. We're kind of right up against the back surface of the cornea, and we're just spreading, dissecting all the way through. If you notice, the cap cut extended over the side cuts a little bit. That's kind of an intentional design to make sure it like fully frees the lenticule. So we're just following that all the way along. This can be done in as few as just a couple swipes here. So once we're positive that's free, then we can use that kind of channel we pre-dissected in the posterior portion. And again, there's many ways to do this. My method just involves leaving a couple tags near the lenticule or the incision to access the lenticule. So if you notice, I didn't dissect that part to the left of the actual opening right here. That's kind of highlighted in white. We're not going to dissect those parts yet. We're going to make sure we kind of free the rest of the lenticule. The reason is if you free those parts accidentally, the lenticule starts bunging up unintentionally. So there we free one of them, and see the lenticule is already bunging up. We free the other one, and then we just kind of need to sweep underneath the lenticule to free it a little bit until we externalize a small portion of it. That's enough. This person's kind of fighting a little bit. That's okay. Then we grab the lenticule here and pull it out, and I like to just take a little extra time to make sure it's complete and intact. Don't want to leave any pieces of the lenticule behind. So that's nice and round. That's kind of a thinner, lesser treatment, I would say. Then this is an optional step as well, is just rinsing out kind of the pocket where the lenticule was. And then after this, it's just kind of the antibiotic drop. And then that's it. There's essentially no restrictions. The eye still looks pristine. It's pretty hard actually a lot of the time to tell if somebody's had Smile because The only really evidence is that little the incision opening at the top of the cornea. So PRK really only represents a minority of cases kind of in a modern refractive surgeon's arsenal. LASIK is way safer than people give it credit for. So PRK is kind of like a fringe case use, in my opinion, at least. So it's really performed, for myself and for us when all other procedures are kind of deemed unsafe. So we try to avoid it in hyperopia. It can regress with kind of large treatments. And it's essentially identical to LASIK, except the first step is we use kind of this disc soaked in alcohol to remove the epithelium first before actually treating the cornea underneath. But otherwise, similar concepts, similar nomograms to program treatment of the laser, and really similar otherwise. So moving into kind of coming back actually to the lens-based treatments is FLACS. So like I said, this is femtosecond laser-assisted cataract surgery. One thing I really want to emphasize is that every single cataract surgery is a refractive surgery. So with the use of lasers, astigmatism is very precisely corrected. The lasers can do really cool things like place tags on the actual rexus where we can align the torics very accurately. It also allows the lens to be softened beforehand, so it's even easier to remove and healing can be a little bit faster. Going back to every cataract surgery is a refractive surgery, that should be the thought for every cataract exam or referral or really anything, is that this is a really good chance to customize this patient's vision to their lifestyle, their wants, needs, goals, and things like that. So while you're in the eye, also correct the prescription, correct the astigmatism, and give them independence from glasses, right? If that's what they want. So here's just a short video of what the laser looks like when it's actually firing. So again, similar to the ICL video I showed earlier, it makes the rexus first, and then it cuts the actual lens into little pieces of a pie, basically. So they're broken up and really easy to remove during the actual procedure. The last thing it does is it makes those arcuate incisions, if you can see kind of towards the top of the screen there. And that's about it. So that's it. The modern lasers take under 60 seconds and are extremely fast. Kind of continuing that thought is the RLE, which is the refractive lens exchange, also called lens removal. That's the removal of the crystalline lens before it's cataractous and cloudy, when it's still dysfunctional, right, or presbyopic. So this allows kind of patients early access, I like to say, into their next stage of vision. So instead of waiting for the cataract to get so annoying that it's causing glare and halos and making everything yellow and blurry, and it happens again so slowly that most patients don't even realize it. We just kind of jump to that next step early, especially utilizing advanced lenses like the multifocals or the LAL. I'll just play this whole video again just to emphasize how quick this is. I think this is going to take under 5 minutes. So again, we do a paracentesis here. This is after the femtosecond part, again, you saw earlier. Then we use that OVD again, very similar to the ICL, and then make this main incision. Modern IOLs are all flexible, typically made out of acrylic or silicone, so they can fold up really small and be inserted through these tiny openings. The rexus that the laser cut is usually free, so we just move it around, make sure it's not attached anywhere, and extract it. Then similar to normal cataract surgery, we do a hydrodissection to free the lens from the capsule that it's sitting in, and then begin the actual phaco part. So here is the phacoemulsification, which is just ultrasound energy. The probe is just moving at the speed of sound to basically liquefy the lens or break it into tiny pieces. This is just kind of our technique for femtosecond laser cataract surgery, where we're kind of creating a pit in the center of the lens and then working with what the laser has already carved for us, right? So we made that pit, and then we can easily access the different pieces. See how easy those come apart with the laser? So again, this just makes cataract surgery so easy and so safe, and so precise also, with the, like I said, astigmatism correction and ability to just be precise with the rexus and things. Another example is you can actually, nowadays center the rexus to the optical axis to kind of ensure the good centration of the lens as well. So here we are just, continuing to divide the lens along its kind of predetermined lines. You can see how gentle everything can be with femtosecond laser, and then getting the rest of the pieces here. And then if you see in the upper right corner, the CDE is just kind of a measure of energy. Really anything 5 is kind of like normal for most cataract surgeries, I would say. Anything around 2 is like effectively no energy. So again, this is just so little energy giving to the eye that we expect almost no swelling and a kind of a faster visual recovery with use of the laser. Here is the, just like any cataract surgery, the cortex kind of has to come out next. So that's kind of the M&M coating, candy coating of the actual lens. So here we are pulling and gently removing that cortical component to the lens. This is kind of done in these big sweeping motions, getting these big sheets. And then last thing is kind of this polish setting to get those last little guys towards the bottom there. So this capsule looks really clean. Cataract is out already. And, I think this has been like under 3 minutes already. So we're going to kind of prepare the lens. Either here we would do, use something technology like Aura, which is like an intraoperative aberrometry where we take one more measurement of the eye. This case, we're using the LAL, which is adjustable after surgery. So we have, somebody preparing the lens who will then kind of hand it to us. And with the LAL, it's a silicone lens. Like I said, it's adjustable after surgery, so it allows really great precision, either for people wanting to kind of sample blended vision or who have a history of refractive surgery. So here is the lens going in the eye, and we just kind of finish by spinning it in where it needs to be in the capsule. And then the last part, really just kind of similar to that ICL again, is to wash the OVD out of the anterior chamber again. So that's the lens nice and centered here. And like I said, the last part will really just be this rinse here. So we remove all this OVD. Perfect. And then, I like to just get it from behind the lens as well. So the lens is definitely kind of sitting in a really realistic position where it will be sitting later. And then we add kind of antibiotics and a steroid here, so to kind of reduce the drop burden for the patients. And then that's really it. So, if you were kind of paying attention to the clock, I really think this whole procedure takes under 5 minutes. So cataract surgery has never been safer or easier. So, it's never been a better time to get a refractive procedure. Here is just doing that kind of additional antibiotic and steroid. So our patients only need to take drops one time a day. So, lastly, kind of think about what about keratoconus or patients with, real eye disease. So anytime keratoconus comes up, you're kind of thinking of two things. So like one, stop progression, stop it from getting worse. That is achieved through corneal cross-linking. Again, corneal cross-linking is just a procedure where the epithelium is removed, riboflavin is applied, and throughout the time, and then a UV light is applied to the eye to kind of induce free radical formation and glue the cornea into place. That's not going to correct vision, and patients should know that. They sometimes find it unsatisfying, but it's very important to stabilize the disease and stop it from getting worse. Step 2 is correct vision. So that can be done in two ways. So if they have very mild keratoconus, that topography-guided PRK is a great idea in combination with cross-linking, which again just kind of isolates the cone and makes the eye more regular and thus more treatable with contacts, glasses, something. Moderate keratoconus can be treated with CTAK, like we talked about at the beginning. So PRK with cross-linking, so again, using Contoura, that topography-guided LASIK, the cone is really isolated through these scans and then normalized. So the cornea has been normalized. If you can see here, it's gone from this large cone inferiorly to what is regular astigmatism. So now this can be corrected, and now vision potential can be much higher after correction. CTAK is a newer procedure for sure, but it's really interesting. So the patient's penniculum is processed through a proprietary nomogram through the company CorneaGen, and then human donor cornea is cut for each individual patient kind of according to a plan. So this is like an example plan here. So a femtosecond laser then makes the actual channels in the cornea, and then the donor tissue is kind of inserted into those channels in the OR. It's really cool because results are almost immediate. And if you can think, the whole idea here is to flatten and regularize the cornea. So in this kind of plan picture that it's showing here is that magenta line at 139 is the opening to the channel. That kind of dotted line around is the actual channel to be carved with the femtosecond laser. And then the yellow segment is actually the human donor cornea tissue cut to specification to be inserted into that channel to normalize the cornea later. So here's just a video. So the CTAK is really first washed, and then a lot of marking, a lot of refractive surgery is preparation. So we often hang that plan, like I just showed you, right here, up here, to know exactly where to, how far to advance things, and where the CTAK should be sitting at the end of the procedure. So this is after the femtosecond creation, and then we just start to kind of open the channels here, as you can see, and then they need to be dissected fully. So we use these kind of special instruments that kind of look like pigtails here to kind of wind them into the channel. And we're really, if you can see, there's kind of a lot of rocking going on because we're making sure we're dissecting the entire width of the channel. CTAK is fairly large. I would say the predecessor to CTAK was INTAK, which was initially developed to treat myopia. It's a very similar concept to CTAK, except it used PMMA rigid plastic inserts instead. There were problems with those. They would extrude through the cornea, but they were used to treat keratoconus for some time. The CTAK is just much more biocompatible, obviously, since it's human stromal corneal tissue. Same thing in the other direction. We're just dissecting the channel, making it easier to access. The combination of both of these will, allow the CTAK hopefully to slide very easily into the actual channel. So then we take that prepared CTAK and kind of get it ready for the insertion here. And like I said, all that planning that we've done, we've made our marks. So this is kind of where the tissue needs to actually be sitting within the channel. So I like to kind of lift the lip of that channel and start inserting the actual tissue into the channel here. We can kind of pin it down to make sure it stays in the channel. And then it's just a matter of kind of advancing it along and ironing it out, because this can kind of get bunged up too. So you use kind of a special instrument that comes in these kits to iron it out later. So we advance it in. It's kind of a combination of pushing it and bunging it up and then kind of unfurling it here. So just kind of this back and forth of push and then unfurl. So we do this for a while until we get it in those positions that we've predefined on the marks. So just more pushing and ironing here. This is really cool too. It doesn't really require a lot of instruments. A couple of the instruments are expensive, but the barrier to entry is quite low too, honestly, for the procedure. It's kind of a familiar skill set. For the patients, it's really easy. Again, the incision to open and access the channels is so small. It's really shouldn't be more uncomfortable than SMILE, for example. So it's also a really comfortable and easy procedure, kind of, especially compared to cross-linking, which can be a little more involved. So here, again, we're just advancing that back part of the CTAK to that position, and then we kind of know that, well, it must be bunged otherwise. So we're just working on kind of ironing it out and flattening it out to get it where it needs to be. This procedure is also quick. I didn't play this in real time, but it also is between 5 and 10 minutes. So here we are just continuing to iron it out. That's looking pretty good, and now you can see the two edges of the actual tissue are at the two lines that we previously defined. Just a couple extra strokes to make sure it's really flat in the chamber. And then sometimes we add a BCL. It's normally not necessary, but that looks really good. And then the results are astonishing. So here is a kind of before and after. So pre-op we have this 2100 correctable to 2040 kind of situation, and then this nearly 60 diopter cone. CTAK works best if the cones are more central. And then post-operative, this is I think almost 2 months after the procedure, so we expect it to get even better, but already better than uncorrected, better than they were before. So 2030 uncorrected, and now they're pinholing to 2025. And if you look at the actual topography, 12 diopters of flattening there. You can kind of see that elevation peripherally of the actual tissue where it's sitting. But again, that's the trade-off, is to steepen that area to flatten the central cornea where they're actually looking through. So kind of a summary. This is a graphic that we made not too long ago. It's kind of vision correction procedures by age vaguely. So kind of this is when you should start thinking about certain procedures over other procedures. Kind of, again, depending on age, honestly, there's sometimes some ranges where it gets a little blurry and fuzzy, and then some are slam dunk for one procedure. But it's really a dynamic process of refractive surgery. It's, like I said, an art, and it's really about talking to people and understanding their wants, goals, and needs kind of as much as possible. If you're interested in learning more, we did publish a textbook on refractive surgery that's available on Amazon. The second edition has lots of example cases if you really want to kind of do a deep dive into understanding more about each procedure and how it's applied and pre-op and post-op kind of findings. But refractive surgery is really cool. My life's been changed for it. It's absolutely an honor to help change other people's lives with refractive surgery too. So hopefully you enjoy and consider refractive surgery as a career yourself. So thanks for your attention.